Hello and welcome to the case of the week. In this interesting case, there are several problems. The patient has a failed corneal graft, refractory glaucoma that has failed tube implantation surgery, and also has a dislocated intraocular lens optic. The goal of this surgery is to retrieve the optic and then effect endoscopic cyclophotocoagulation so that once this patient has achieved a normal intraocular pressure, may undergo revision of the corneal graft. And here is a view of the dislocated optic. This is a view of the ciliary processes. So the first part of our treatment will be to remove the vitreous and then perform ECP. Since this is a refractory form of glaucoma, the failed corneal graft, we want to perform a relatively intense treatment. Otherwise, intraocular pressure will not be adequate. So here we could see the ECP progressing nicely with whitening of the ciliary processes in a uniform fashion. The pigmentary disruption that is visible anterior to the processes is due to misplaced transscleral cyclodestruction done elsewhere. One of the great values of ECP is the visualization of the ciliary processes and control of the laser application to the ciliary epithelium so that only the aqueous producing tissue can be treated. This white area superiorly is actually a failed trabeculectomy site. Our goal is to photocoagulate 360 degrees of the ciliary processes in a fairly intense manner without causing explosions of the processes themselves. If some of the photocoagulation spreads onto the pars plana in an attempt to reach the tails of the processes, this will also give us an additional benefit in controlling intraocular pressure in these refractory glaucoma eyes. This is the plus treatment of ECP, where the processes plus a confluent row of the pars plana is photocoagulated. Most patients who undergo this intensity of treatment develop intraocular pressures in the single digits as a long-term outcome and usually completely eliminate their glaucoma medications or wind up using perhaps one medication long-term. The more of the pars plana epithelium that's lasered, the lower the intraocular pressure will go. However, one does not want the lesion to extend anterior to the sulcus because that tissue does not produce aqueous, and such treatment will only result in inflammation. A second sclerotomy site is observed, and we're approaching the ciliary ring from a different point of view. Again, the ciliary epithelium is completely lasered without causing explosions, and a confluent row of photocoagulation lesions are also placed below the tails of the ciliary processes onto the pars plana in the so-called plus treatment. Often, this treatment will result in breakdown of the blood aqueous barrier with more flare postoperatively. In these eyes, we usually inject 0.1 to 0.3 cc's of Decadron coming from a 4 milligram per cc bottle in order to limit any postoperative inflammation that might be observed. This is the last patch of processes that completes the 360-degree ring. I find it very helpful after I've treated the ciliary processes to go back over them again and look for areas that perhaps I missed or didn't take up the laser as I originally thought they did. The ultimate goal is to have a uniform, intensely white ring around the eye that incorporates all of the ciliary process tissue, and when using the plus treatment also incorporates this millimeter or so of pars plana. So now we have a panoramic view of this uniformly whitened ciliary ring without any untoward effect. Our next goal is to retrieve the lens optic. This is difficult. An intraocular forceps is used to grab the edge of the optic. It's usually easier to grab the haptic, but there aren't any here. This explantation was unsuccessful, and so perseverance is required. As an alternative method, perfluorocarbon liquid is injected into the eye to float the lens optic off the surface of the retina to make it safer to grab. Unfortunately, with the infusion still running in the eye, the lens implant swirls around like a flying saucer. So the posterior infusion has to be turned off for this portion of the surgery. When this is done, the lens implant stops swirling and it makes it easier to grab it. Once the implant is grabbed with the forceps, it is brought out through the generous sclerotomy. Once the optic is removed from the eye, the perfluorocarbon liquid is aspirated, and it's fairly simple to do under endoscopic control because the liquid itself has a different specific gravity than the BSS that is otherwise filling up the eye, and so the edges of the perfluorocarbon liquid bubble are easily seen. The goal here is to aspirate all of the perfluorocarbon liquid, since in the long run this material is toxic to the retina. The bubble's very small now and pretty much gone from the eye. So at this point, the glaucoma has been treated, the optic has been removed from the eye, the perfluorocarbon liquid has been removed, and all that needs to be done is to close the surgical wounds and inject some of the intraocular Decadron. Well, we hope you enjoyed that. See you next time.